Muy buenos días. Tengo el honor y el enorme placer de presentarles a ustedes al doctor McIntyre. Algunas líneas acerca del doctor. El doctor McIntyre actualmente es profesor de psiquiatría y farmacología de la Universidad de Toronto y el jefe de la unidad de trastornos del humor, psicofarmacología de la Universidad Health Network, Toronto, Canadá. Dr. McIntyre está involucrado en varios esfuerzos de investigación que tengan como primer objetivo caracterizar la relación entre los trastornos del estado de ánimo y la comorbilidad médica. Esta investigación incluye la aclaración de los efectos adversos metabólicos asociados con el uso de medicamentos psicotrópicos, el impacto de la comorbilidad médica en el curso de los trastornos del estado de ánimo y el efecto de la homeostasis de la glucosa en la neurocognición. McIntyre está ampliamente involucrado en la educación médica. Es un orador muy solicitado en las reuniones nacionales e internacionales. Ha recibido varios premios de enseñanza de la Universidad de Toronto, Departamento de Psiquiatría, y ha sido beneficiario de la Asociación Canadiense Conjunta y Consejo Premio de Educación Continua de la Psiquiatría para la Educación Continua, actividad más destacada en psiquiatría en Canadá. El doctor McIntyre es el copresidente de la Red Canadiense para el Estado de Ánimo y Tratamiento de la Ansiedad, grupo de trabajo sobre el tratamiento de la comorbilidad en los adultos con trastorno depresivo mayor o trastorno bipolar, y también un contribuidor a las directrices de CAMA para el tratamiento de trastornos depresivos y bipolares. El doctor McIntyre ha publicado extensamente en revistas y libros de textos tratados por pares. El doctor McIntyre es también un revisor de varias revistas, incluyendo la revista American Journal of Psychiatry, la revista Biological Psychiatry, Journal of Clinical Psychiatry y el New England Journal of Medicine. El doctor McIntyre completó su título de médico de la Universidad de Dalhousie y recibió su entrenamiento en residencia psiquiátrica y fellowship en psiquiatría farmacológica en la Universidad de Toronto. Vamos a recibir con un fuerte aplauso a nuestro distinguido disertante, el doctor McIntyre.
Gracias, thank you very much for the introduction, and good morning, everybody. What a beautiful center, a beautiful location for the meeting, and congratulations to the organizers for such a successful attendance and successful execution of the meeting. Nice to see friends again. I've already had the opportunity in the last day to have bumped into several colleagues and friends that I've met over the years. So wonderful to be back here in the beautiful Dominican Republic. Today I've been asked during this symposium to speak to the topic of treatment strategies in major depressive disorder. It's a big topic, lots we can cover, and I want to make sure that I, in fact, am successful at executing what I'm intending to do here today, and that is to, in fact, share with you results from clinical trials that provide support for the notion that antidepressants that we currently have for the treatment of major depressive disorder are not all identical when it comes to efficacy. There's been a tremendous amount of interest in the efficacy of antidepressant medicines, as there should be. Depression is a common illness. It's often severe. It's an illness which we now know to be the leading cause of disability and premature mortality around the world. So this is, in fact, a public health issue, being depression. We also know that antidepressant prescription is common in many jurisdictions, many regions, countries around the world, and the prescription rate for antidepressants has been increasing. For example, today in the United States of America, 10% of all people over the age of 13 are prescribed an antidepressant. 10% of all people over the age of 13. So this is a category of medicines that the population is exposed to. At least they're prescribed. Whether they take them or not is a different issue. What everyone wants for their patient is a good health outcome. And part of the pathway towards a good health outcome includes offering patients medicines that are the most effective and obviously safe and well tolerated. Unfortunately, the way clinical trials are designed with most antidepressants is that they don't provide for the clinician, the psychiatrist, the family physician, in some areas the nurse practitioner who can prescribe medicine, doesn't provide sufficient evidence to really say, you know, this drug is definitely more effective than that drug. And that's a long discussion why that is. That's a 3-hour symposium. But what we have in fact come to agree is that if in fact we design clinical trials where we target populations that are enriched or populations that are characterized or stratified, we're more likely to see a difference between agents on efficacy. So what I'm going to show you here today for the next 45 minutes or so are studies indicating that there are differences in efficacy between SSRIs. What I want to underscore, that is what I want to really emphasize, is that the opportunity to show the superiority of one SSRI over another SSRI is best illustrated in those patients who have a more severe depression. This is a disclosure slide of the different organizations that support the research and activities that I'm involved in at my center in Toronto. Now, the first point in the conversation starts with, what are the therapeutic objectives? If we are trying to select an antidepressant that is more effective than another, then what we're actually saying is that that particular antidepressant is more likely to assist my patient at achieving the therapeutic objectives. The therapeutic objectives over the last 10, 15 years have evolved. It started off with just get symptoms a little better. It moved into response, that is, reducing symptoms 30, 40, 50%. Then we started to talk a lot about remission, that is, symptomatic elimination. And the last several years, and certainly the future, is going to be about functional recovery. By the way, changing the therapeutic objectives is common in chronic disease management. We see this in blood pressure, with diabetes, and other areas. And the effort to try and offer patients the best opportunity for health outcome involves constantly thinking about revising the objectives. No one's going to stand up and say they don't agree that we want functional recovery. But what we have learned is that symptoms do matter when it comes to functional recovery. But symptoms are not the only thing that matters, at least traditional depressive symptoms. And I'm going to be saying a couple of words, not many, a couple of words about cognition and what role it might play in function. I'm also going to say a couple of words about the disconnect between symptomatic trajectory and functional trajectory. In other words, there are some treatments that we have in psychiatry that might better assist a patient in their functioning, their quality of life, what some would call positive mental health, even though the overall reduction in depressive symptoms may be similar. This is, in fact, a question that was posed to patients. The question posed to patients is, if you were fully recovered from depression, what would that mean to you? Now, the starting point of the conversation is that we asked most clinicians, if your patient is in remission, what would that mean to you? Many clinicians would say their symptoms have been eliminated as the first checkbox on the list. Absolutely, symptomatic improvement means something, it means a lot. But when you talk to patients, they don't respond to symptoms right away. What they say is, I want to feel more positive mental health, I want to feel myself again, I want to feel functional recovery. In other words, symptoms matter, but symptoms are lower on the list of priorities when it comes to the therapeutic objectives from the patient's perspective. And this is, I think, fueled a fundamental shift in how we think about chronic disease management. It's not only about our perspective, it's also important to take into consideration the patient's perspective, and as well as the larger society and those who are paying for the service, because they, in fact, also have their expectations of outcome and depression. So feeling better means a lot, but feeling better does not always mean functioning better. And functioning better has now become the new talking point, the new mantra, the new objective. And I don't think, again, anyone's surprised by this, but I think what's particularly interesting to me is that when you look at symptomatic and functional outcomes in depression, they're correlated, but the correlation is not very high. It's on the order of 0.4 to 0.6, depending on the study, depending on the subpopulation. So the point is not that symptoms don't matter, symptoms do matter. But symptoms have a fairly rough correlation or crude correlation with overall functioning. What this slide is illustrating, and this was the results from a clinical study that was orchestrated by a group of investigators in depression. There's a principle that's really interesting in this slide, and that is if you look on the left, you can see the overall improvement in depressive symptoms between the two agents. And the two agents look very similar. In fact, there's no significant difference between groups in the overall reduction of symptoms, at least as measured by this benchmark called remission. But on the right, even though the symptoms are similarly reduced, one of the treatments appears to have a greater capability of improving function. Now, I raise that because as a clinician, one of the observations I have had, I see this more in my bipolar patients who take treatments like lamotrigine. Lamotrigine is capable of stabilizing patients' mood during the maintenance phase. Lamotrigine is no more effective at reducing the risk of relapse than would be lithium or some of the atypical antipsychotics. Yet for some reason, patients who take lamotrigine report a higher level of quality of life compared to other mood stabilizers. They report more positive mental health. And they also report a greater acceptability of the treatment. And this is an observation I've had over the years. And there's something going on. I don't think we really clearly know what that is. But the point is that there are, in fact, more than just symptoms that are driving the functional outcome, the quality of life assessment, the acceptability of the treatment. This is a busy slide, and it's talking about interference of symptoms in day-to-day activity. And on the far right here, over here, where's my mouse? Oh, I beg your pardon, sorry. I don't find a pointer now. Yeah. So over here on the top right, in the top right, right over here, you can see symptoms mentioned. And what this is a very simple assessment, a very simple report, frankly, in perspective, that looks at what are the symptoms that interfere with quality of life, functioning, and returning back to their usual health. And you see the familiar features of fatigue and residual symptoms like that. And you also see cognitive symptoms. So the first point is that we know that symptoms correlate with function. Functional recovery is the objective. Symptoms correlate with that, but it's a crude correlation. And within the rainbow, or within the full spectrum of depressive symptoms, there are some domains that are more likely to interfere with functioning than others. And those are the ones that are listed in the top right. Cognition is an area I have a particular interest in as an academic and also as a clinician. I have been always amazed at how often I see patients with major depression who are well educated, have a university degree or have a college degree or a degree in some type of higher learning beyond high school, who are completely disabled. In fact, 20% of people who have major depressive disorder are permanently disabled because of the illness. 20%. Another 20% fully recover from the illness, fully recover back to work, performing at 100%. The remaining 60% have ongoing functional problems. So 20% are permanently disabled, and 60% have some level of disability. And that disability is driven in part, not entirely, but in part, by these cognitive deficits. If you're sitting there thinking to yourself, I've heard this before, this isn't new. I came to this beautiful resort in Dominican, and he's telling me what I already know. Well, you have heard this before. You've heard this in schizophrenia, and you've heard this in bipolar disorder. But this point has not been pressed in the area of major depression. When we think about antidepressants being different from each other, there's the familiar framework of efficacy, whether it's the speed of onset or the overall remission rates, that is the depth of efficacy. Maybe it's the ability of that medicine to target a particular domain, like cognition or pain. For example, we are familiar with the fact that some antidepressants, like tricyclics and some of the SNRIs, are more effective in mitigating pain for diabetic pain or neuralgia-related pain. That's just a fact. So there are differences in medicines in their domain profile. You're going to be hearing this afternoon during our symposium about a new medicine that's particularly effective for treating cognition in depression. So antidepressants appear to have something in common, that is, they can reduce depressive symptoms. But there are differences in their ability to improve outcomes in domains, like pain or cognition. There's also some medicines that may be more effective in patients who have more severe depressions. There are some medicines that may be more effective in patients who have more anxiety and depression. So there's different ways we can think about this. The reality is that the way clinical trials are done in psychiatry, wherein the primary aim is to demonstrate that the antidepressant is better than placebo, and that's not because the sponsor wants to receive an approval. What we as clinicians are wanting to know is how does that antidepressant compare to other antidepressants? Unfortunately, those types of studies are not very frequently done. And they're not very frequently done because they're difficult to do, they're very costly, and it would take a very high level of collaboration for people to do such a study. Notwithstanding, we can do meta-analysis, pooled analysis, and so-called network analysis. So there are three types of analysis. There's the meta-analysis, the pooled analysis, and the network analysis. So the meta-analysis, which is the more familiar, is when you take the results of a clinical trial and you just compare the results of the different clinical trials. So your variable of interest is the result of a clinical trial. A pooled analysis is when you take the patient-level data from each of the trials. So let's say you had 2 studies, and both studies had 100 patients. A meta-analysis would just compare the results of the 2 studies and determine how good a drug is versus placebo or a comparator. In a pooled analysis, you would actually pool all 200 patients and reanalyze the data. A network analysis is a bit more complicated. A network analysis assumes that if drug A is better than drug B, and drug B is better than drug C, that must mean drug A is better than drug C. Those are network analyses. So if you look at this slide, the way you read this is on the right-hand page. See, where's my slides, guys? Okay, so if you actually look at this slide, what you can see based on this analysis, this was a comparison of escitalopram versus other antidepressants. If the dots fall on the right side of this line, that's superiority in favor of escitalopram. If it's on the left side of the line, that's superiority in favor of the other agent. And what you have is a fairly consistent observation that compared to other SSRIs, escitalopram was superior in efficacy. That's for all patients with depression. This is looking at patients with depression whose MATRA score is 30 or greater. That's a severe depression. And in patients who have a severe depression, what you can see is that escitalopram is significantly more superior to other antidepressants. When Lundbeck developed escitalopram, they did not expect this medicine to be superior to other antidepressants, including citalopram, and fluoxetine, and paroxetine, and sertraline. They didn't expect that. They expected to have another antidepressant that may be better tolerated and easier to take. So this came as a bit of a surprise, frankly, and a very consistent finding. This is replicated and it is consistent. That's for all the SSRIs. This is now just looking at paroxetine to escitalopram using response and remission criteria. And what's interesting is it doesn't matter how you define response or remission, there's a consistent signal that escitalopram is superior to paroxetine in achieving that therapeutic objective. What about, in fact, looking at the pooled analysis of escitalopram and paroxetine? You can see something very interesting. This is, in fact, the baseline MATRA score, 22, 26, 30, 34, keeps going up here. What that slide is telling you is that as the patient's level of depression severity is increasing, they're becoming more severely ill, the difference between escitalopram and paroxetine is more pronounced. The difference is even greater. So this tells me as an academic that when you're looking at efficacy data between agents, it's important to have some of this background information because it will moderate the outcome. Earlier I said that escitalopram had a superiority, but that superiority becomes even greater as the depression severity increases. And we see that with remission rates versus paroxetine using this definition of MATRA 12 or less. What about, in fact, looking at citalopram and escitalopram together? And this is a very interesting analysis because citalopram is a racemic mixture. It's comprised of S and R citalopram in equal molar concentrations. And what's so interesting to me here is that even though escitalopram, which is an isomer, of the racemic mixture is being compared to citalopram, I would have expected they would have a similar efficacy. But you're seeing superiority of escitalopram pretty consistent, and again, that superiority is even greater in those who have more severe depression. There was a separate analysis done with escitalopram where investigators went to the available evidence and had a look at the evidence and compared all the antidepressants that were out there. And the effort here was to find out which antidepressants were superior in efficacy at a definite level of confidence. Which antidepressants are superior in severe depression. And the results of this are listed here, where escitalopram, clomipramine, and venlafaxine were superior to other antidepressants. These are the three antidepressants that consistently demonstrate superiority over other SSRIs particularly. In severe depression, what emerged was for escitalopram. So again, this notion that all the antidepressants are the same in efficacy is not supported by the evidence. This is looking at escitalopram at 20 milligrams per day versus venlafaxine at 225. My view strongly is that venlafaxine is a unique antidepressant. I think it is a more effective antidepressant than fluoxetine in my experience, and the evidence supports my experience. Venlafaxine at 225 milligrams per day is an SNRI. You're engaging not only serotonin, but you're also engaging norepinephrine. When you're comparing escitalopram to venlafaxine, you want to use a high dose. This is the most effective dose of venlafaxine. What you can see is that escitalopram at 20 milligrams per day, which I think is the preferred dose in many of the patients in my clinic, you can see here at least comparability, if not superiority, of escitalopram versus venlafaxine on reducing symptoms at the endpoint. This is looking at escitalopram again versus SNRIs in the group that has a more severe depression. So the earlier slide was all people. This is just in those with severe depression. And you can see a consistent finding that actually escitalopram is superior to SNRIs in this subpopulation that psychiatrists so often see. And I think that's very handsomely illustrated in this particular slide, where escitalopram versus venlafaxine XR is listed, and a pattern now is emerging where as the baseline severity is increasing, you are seeing a greater separation between the two groups. So a consistent finding. There's not a psychiatrist or a healthcare provider who is surprised to hear that when you're talking about SNRIs, no one's questioning their efficacy. But where we struggle is with treatment-emergent adverse events, as well as discontinuation emergent adverse events, the discontinuation syndrome. So I've just been focusing on efficacy. Everyone here knows it's more than that. Side effects do matter. Safety does matter a lot. And I think it's not a surprise then to hear that SNRIs, compared to in this case with escitalopram, have a much higher rate of adverse events that consequently led to a dropout of that patient. So in the interest of time, and I know there's a lot of data here, I've got some tables I will share with you that briefly and succinctly summarize the literature that's out there comparing escitalopram to the other SNRI, in this case it's duloxetine. It's a busy slide, so I'm going to ask you just to look at this column over here. These are different studies looking at escitalopram versus duloxetine. And a consistent finding is that escitalopram is as good, if not superior, on efficacy. And a consistent finding, no surprise, that it's superior on tolerability. This is looking at the adverse events, and we operationalize the percentage at 10% or greater. And again, I don't think any clinician is surprised to see that. Some of the adverse events being more common in the duloxetine treated versus the escitalopram treated group. So I have, moments ago, made reference to so-called meta-analysis, where you analyze just the results of the trial. A pooled analysis is when you analyze all the patients in all the trials. This is now a network analysis. And this allows you to compare antidepressants together indirectly. So this is important because we don't have a lot of head-to-head comparisons in psychiatry. And I think many would have seen this analysis. This was at an arm's length from Lundbeck. As far as I know, Lundbeck had no involvement directly or indirectly with this. Now, these investigators have their biases, we all do. So to say they have no biases would be disingenuous, would be frankly dishonest. Everyone has biases, but this was not fueled by Lundbeck. And what they did is they looked at a dozen antidepressant medicines, and they looked at efficacy, which was defined as response, 50% or greater was the usual definition, as well as acceptability, which was really a statement about dropouts. And they looked at a dozen first, line and second line antidepressants, and you can see what actually happened in this clinical study. It turned out that there were 4 antidepressants that were consistently superior to the others on efficacy. Escitalopram, sertraline, venlafaxine, and mirtazapine. And that doesn't surprise me. That is, in fact, an accurate reflection of the data. On acceptability, that is the dropouts, you can also see differences between some of the antidepressants. And the agents that had a better acceptability pattern were escitalopram and sertraline. And 2 others here being the appropriate ones you can see as well. I think that's quite fair. So taken together, when you balance the efficacy with the tolerability, you get a very different characterization of the antidepressants. So along the x-axis is efficacy, and along the y-axis here, you can see the issues around tolerability, or so-called acceptability, which includes tolerability. Because patients drop out of a clinical trial if they're having terrible side effects, but they also will drop out of the clinical trial if the terrible side effects are not being offset by efficacy. So acceptability is kind of a complicated phenomenon. But what you can see here is that all of a sudden antidepressants don't look all the same, because they're not. And you can see, in fact, that there are differences in the antidepressants. So the top right would give you superiority of efficacy as well as the acceptability. And I don't think most people are surprised. By the way you read this slide is if fluoxetine is the reference. And so I don't think people are surprised to see fluvoxamine down here. We don't question venlafaxine's efficacy, but that certainly has had some problems with acceptability. Everyone knows the STAR-D trial. The STAR-D trial was funded by the US government. And it's a trial that is not the focus of my presentation, but there was a publication from the STAR-D trial within the last 9 to 10 months that I think is really interesting. What they found is that in major depression, if patients can be treated to remission, they have a higher likelihood of returning back to work. To me, I'm not surprised to hear that. That's not the conclusion. The conclusion is that if they were able to achieve remission with the first antidepressant in the STAR-D trial, they went back to work. If they achieve remission with the second or third antidepressant, they don't return back to work. So the point being is that we need to offer patients not only effective agents, but our ability to return patients back to the economy, back to the workplace, is greater with the first antidepressant. So we need to give patients those treatments, whether it's a medication, whether it's psychotherapy, combination of the two, those treatments with the greatest therapeutic potential first, not waiting until later. This is what really came out of this trial. And so looking at the workplace domain of function is critical. It's not the only domain that matters, but it is a domain that clearly is critical for the economy, for earnings, for sense of efficacy. And in addition to having a symptomatic and tolerability advantage, there are now suggestions from this literature that you have a functional advantage. Is that because of the symptoms only being greater in terms of improved with escitalopram? I'm not sure. I think it's probably more complicated than that. But we certainly have this signal on functional advantage. These are two studies that are side by side. One's from Austria, the other one is from Canada. And this is an effort to look at, in the real world, not in any artificial clinical trial setting, but in the real world, how does the functional outcomes of patients look if they receive escitalopram? And the way that they define functional outcome is the number of sick days, as well as those people who are off on medical leave. And you can see over time, 3 to 6 months, for example, you're seeing improvements in the number of sick days and the requirement for disability leave. That's critical for an economic perspective. It also gives us indirect evidence of the level of improvement that patients are exhibiting such that they can return back to that environment. So first-line antidepressant medicine is about giving people treatments with the greatest therapeutic potential. My experience as a psychiatrist has been is that most patients don't do sufficiently well with the first-line antidepressant. And we need to actually do something like optimize the dose or switch or combine drugs together. I want to show you some interesting results from some clinical data that provide some evidence on what we can do here. This was actually a study that was done where it was an analysis of a large database where patients started on escitalopram at 10 milligrams per day. And then one of three things happened. If the 10 milligrams was not sufficient, presumably the dose was increased to 20 milligrams, or they had an antidepressant added to the escitalopram, or they stopped the escitalopram and switched to something else. This was a very, very large database. And it turned out that the majority of people in the clinical trial, first of all, in this data analysis, did not require dose optimization. So most people did okay at 10 milligrams per day. But for those who were not in full remission and function recovered, dose optimization was the most frequently chosen strategy amongst this very large sample. And then when you look at outcomes of dose optimization versus switching to something else versus adding another antidepressant, the simple step of dose optimization turned out to be the most effective strategy. There is, in fact, now consistent evidence, and my read of it is that it's consistent, that the 20 milligram per day dose may, in fact, have a higher efficacy than the 10 milligram dose, not in everybody, but in many patients. So the first thing we should be doing if 10 milligrams is insufficient is dose optimization. This is a really interesting study. I was not part of this study, but this speaks to two separate issues. What is the right dose if 10 milligrams is insufficient? And also speaks to the question, that question being, when should you increase the dose? So in this study, what they did was something pretty interesting. Everyone starts off at 10 milligrams a day of escitalopram, and they're on that dose for 2 weeks. If after 2 weeks the patient is not in remission, the patient was dose optimized to 20, or they stay at 10 milligrams, or they switch to duloxetine at 2 weeks. And as it turned out, the dose optimization, that is going to 20 milligrams per day, was superior to the duloxetine switch strategy. So I think the idea of dose optimization needs to be emphasized. You could be thinking to yourself, well, I always optimize the dose. Why is he emphasizing this so much? I'm emphasizing it so much because the prescription data in North America and Europe indicates that psychiatrists do not optimize the dose as much as they could. And we have that data. So dose optimization should occur. When should it occur? In the Canadian guidelines, we stated that that should occur between 2 and 4 weeks after starting the medicine. That's a lot earlier than the 6, 8, 10, or 12 weeks, which was previously recommended. In addition to having dose optimization being the preferred strategy, we did not lose patients in premature discontinuation. And what I tell my patients is that after a couple of weeks being on the initial dose, chances are you will tolerate a higher dose. Okay, so this is in fact a slide on dose escalation. It turns out that with fluoxetine, with sertraline, fluvoxamine, we don't actually have any evidence that dose optimization provides for a greater effect. The only SSRI that's been shown in this type of design was with escitalopram. That has implications for cost. This matters more to some people than others. I work with a lot of government officials in my country. I work with a lot of policy people, as well as with the hospital purchasing. And so this actually matters a lot to us, that greater adherence does have cost advantages. And that means a lot, where dose optimization seems to reduce cost. Let me, if I can now, finish with a couple more slides from a recently published study sponsored by the US government at the NIH. And this is an interesting question. Should we start patients on one antidepressant, or do you start patients on 2 antidepressants? So in this study, they started patients on escitalopram up to 20 milligrams a day, or escitalopram plus bupropion, or venlafaxine plus mirtazapine. This is on day 1. So does 2 drugs work better than 1 drug in depression? It turned out that in this study, which had 2 parts at 12 weeks and at 7 months, it turned out that the remission rates for escitalopram were just as good as the remission rates for venlafaxine, mirtazapine, or escitalopram plus bupropion. That's at 12 weeks. This is in fact looking later, at 7 months later, there's no differences between the groups. So in other words, using a single antidepressant was just as good as using 2 antidepressants in this particular study, based on the overall outcome, response, and remission rates. No surprise, 2 drugs have more side effects. Frankly, to be quite candid, I actually think that this is just the starting point in the conversation, because I firmly believe that there will be a scenario where some patients will do better on 2 medications on day 1. Now, we already know this in psychotic depression. They need an atypical plus an SSRI. But I suspect it's going to be the case for more than just that subpopulation. So this was a very interesting study indeed. So let me just, if I can, conclude by saying that I was here to talk about antidepressants and their comparative efficacy and acceptability. I hope I've convinced you, I've convinced myself at least, that these agents are not the same. And the conclusion that they are the same is not aligned with the available evidence. We are beginning to see differences not only between SSRIs on the issue of efficacy, but we're also in fact beginning to see a really important teaching point. And the teaching point is that you really want to illustrate the differences between antidepressants. What you really need to do, along with having good statistics and good comparative statistics, you need to, in fact, identify patient subgroups more meaningfully, and that may provide a greater opportunity of detecting differences. So in addition to showing overall differences, I also showed you robust differences in the subgroup that has severe depression. And I've also, in fact, tried to share with you an important principle about care around dose optimization sooner rather than later has implications for the patient, implications for us, and also implications for the payer. With that, I'll thank you very much for your attention.
profesor Roger McIntyre por su brillante y bien documentada conferencia acerca del uso de antidepresivos, especialmente sus conclusiones con el uso del Lexapro. Creo que ha sido realmente brillante su conferencia. Y si tienen alguna pregunta, aunque estamos un poquito escasos de tiempo, pero yo creo que no podemos desperdiciar la oportunidad de aprovechar aquí al doctor Roger McIntyre. Si hay alguna pregunta que alguno de ustedes quiera hacer, así que vamos a dar la oportunidad. Sí. Ok, muy bien, muy bien.
Bueno, yo iba a preguntarle al profesor con el micrófono.
Le doy el micrófono a Montalvo para que le haga la traducción.
¿Y por qué no le ponen un headphone a él para que le decida la pregunta? Pues va a haber más gente que le va a preguntar.
Ok, sí, ya estamos dándole su headphone.
Yo iba a preguntarle al profesor su opinión acerca de la asociación de antidepresivos versus monoterapia. Yo tengo mi opinión personal, que es la de Montgomery, que no hay ventajas en la monoterapia, pero el profesor tiró un estudio que es aplastante, que es el de Trivedi, American Journal, mayo 2011, en favor de la monoterapia. No obstante, se persiste en querer asociar antidepresivos, pero la data no es lo suficientemente consistente según los estudios, ¿no? ¿Cuál es su opinión personal? ¿Usted coincide con el estudio de Trivedi?
I'm glad you asked about the Trivedi study and the COMET study. And this was the study that compared escitalopram to escitalopram plus bupropion, or venlafaxine and mirtazapine, 3 different arms. And the question was, what were the remission rates at 3 months and at 7 months, as well as what's the tolerability and what was the acceptability. And the conclusion is that there were no differences between the 3 groups. Some people believe that in part, the reason why the combined antidepressants did not work as well as people thought it would, and was no more severe to escitalopram, is because the medication dosing wasn't fully optimized. Well, my conversations with Maduka Trivedi are that they did look at a subset of people who did have full optimization of the doses, specifically venlafaxine and mirtazapine. And apparently there was still no difference between the overall response remission rates in those subpopulations versus escitalopram alone. My colleague in Ottawa, Canada, Pierre Boulier, has published a couple of small studies at his center where he has shown superiority of combined antidepressants, such as mirtazapine and bupropion, over fluoxetine alone. These are smaller studies, but very well designed trials, showing superiority. So what we have is insufficient evidence to conclude that we should not start with antidepressants. We just don't know that just yet. Because the studies that we have, 2 small studies at a single center, suggest that it could benefit patients to start with 2 antidepressants. The large NIH study does not support that. So I think we still don't know. Now, what's my personal opinion? My personal opinion is I do believe strongly that major depressive disorder goes through a series of stages. And these stages can be conceptualized phenotypically, perhaps even neurobiologically. We're not at a level of sophistication yet to show you a staging schema for depression. By the time patients see us, they typically have had illness for many years and have had more than one episode. Not always, but most times. Their illness has progressed. It is my personal belief, which I'm hoping one day will be embroidered by data, that these patients require 2 and 3 medications on day 1. That's my personal belief. We already know that's the case with atypical antipsychotics in psychotic depression added to the SSRIs. And that's accepted as a standard of care. There's also a large Cochrane review published about 13 years ago showing that benzodiazepines added to antidepressants improve outcomes in depression. And not just because they're sleeping better and less anxious. We haven't studied this, and in every other area of chronic disease, diabetes, hypertension, arthritis, inflammatory bowel disease, combination therapy has been studied and shown to be superior to monotherapy. What about earlier in the illness course? Call that stage 1. I suspect you can get away with perhaps a more simpler regimen. So, my intuition is that you're going to require more than one medicine. But let me just also inject another personal commentary. My other commentary on this issue is that we in psychiatry keep doing what nobody else in medicine does. Nobody else in medicine gives a patient with a chronic disease a pill and expects the pill to be effective for everything. So if you have dyslipidemia or diabetes or hypertension, what you typically have are medicines being selected to target domains or biomarkers. Maybe your HDL to LDL ratio, or maybe your triglycerides, maybe it's your glucose, maybe it's your blood pressure, maybe it's your kidney function. And so they have refined their knowledge to show that some medicines are better in some domains. Admittedly, they have a biomarker than other domains. And I think it's quite reasonable to anticipate that combining antidepressants will not be about trying to reduce the HAM-D score more, although we would welcome that, but instead we're going to be picking medicines to target domains. And what those domains will be is, I can conjecture and put up my own ideas, but I think that's more and more we're going to be seeing in the future. So the evidence does not support starting 2 on day 1. I philosophically believe that there are going to be patients that's going to be the way to go. It's already happening because a lot of doctors are giving patients sleeping pills and benzodiazepines with the antidepressant. That counts as polytherapy. But I think, in fact, what we're going to need to do is we're going to need the funding to do that kind of work. And unfortunately, the NIH does not want to support this kind of work anymore. So I'm not sure we're going to see an answer anytime soon.
En caso de una depresión severa con una sintomatología psicótica severa, ¿con qué antipsicótico usted combinaría el citalopram y en qué dosis?
So, in the studies that I showed that had post hoc analysis as well as meta-analysis of the severe depression group, which was most frequently defined as a MADRS of 30 or greater, those patients were severely ill, but they were not psychotic. Now we know that severity and psychosis often go together, but they were not psychotically depressed. And that's a really important point. Because the treatment of psychotic depression is not with antidepressant monotherapy. It's with antidepressant with atypical. What's the atypical that I would prescribe? I would prescribe an atypical that has evidence And secondly, an atypical that does not cause significant weight gain and metabolic disruption. So my preference would be for aripiprazole. We have evidence for aripiprazole, quetiapine, and olanzapine. Aripiprazole is no more effective than the other two, but it doesn't cause as much weight gain and diabetes. And patients with major depressive disorder have an extraordinarily higher rate of overweight, metabolic problems, and metabolic syndrome. And we're now learning that if you have a mood disorder, as well as having a concurrent metabolic problem, in addition to having a higher risk for cardiovascular disease, you may also be more susceptible to cognitive impairment. Because obesity and diabetes result in cognitive impairment. So it makes no sense to me in the sequencing of atypicals to give a patient a drug that causes a lot of weight gain if the alternative has not been considered first. The alternative may not be available, maybe they can't afford it, maybe they can't tolerate it, but it has to be considered first. Aripiprazole, 2 to 8 milligrams. If that failed, I would consider quetiapine. I don't prescribe olanzapine very often in major depression. The weight gain is too prohibitive, and I think they have other options. So what we do off-label, is we will give them Safras, 5 to 15 milligrams. We have another agent called Latuda, off-label, 20 milligrams to 60. Latuda has been recently FDA approved for the treatment of bipolar depression. So those are my agents. The other atypical, ziprasidone Zeldox, or Giordano. Ziprasidone is not a very good antidepressant, so I don't use it very much. But it has a lower risk of weight gain. So I think that we need to go with those agents first.
Yes, sir.
Ok, vamos a permitir una última pregunta por razones de tiempo. Les recuerdo que el doctor Roger McIntyre tendrá una conferencia esta tarde y una cena en la noche. Así que vamos a permitir una última pregunta.
Yes, thank you. I would like to know if you have any experience in working with augmentation in case of refractory depression with modafinil.
Sorry, I didn't get that. What was it? It didn't translate. Can you translate it in English?
I was talking in English for you. The question I made for you in English.
Oh, I'm listening.
My question is, yeah, I'm sorry, I know. My question is, you have any experience working in case of refractory depression with modafinil plus another antidepressant medication?
Yeah. So the question is a good one around modafinil. Modafinil is a stimulant-like agent. It's not a stimulant. It's stimulant-like. It does have effects on the dopamine system. That's been shown now with PET studies using a ligand. So we know it has dopamine effects in the brain. For the longest time, we didn't know what modafinil did in the brain. But it does have an effect on the dopamine system. And you would know that in healthy volunteers, modafinil has been shown to improve cognitive performance, some measures of cognition versus placebo. Modafinil has been studied as an adjunct to SSRIs in major depression. And frankly, the results are kind of average to below average. It doesn't look that strong as an antidepressant. But it does have, as you might expect, benefits in the area of fatigue and daytime somnolence, and that matters. In my clinic, we use it off-label to help patients' cognition. Modafinil has not been studied sufficiently for cognition in major depressive disorder. So I'm using it clinically based on my own hope that it may help the patient. And we've had some benefit in that regard. We have seen some benefit, 200 milligrams to 400 milligrams with modafinil. But modafinil has not turned out to be a very good antidepressant on its own so far. And some may know that there's an isomer for modafinil called R-modafinil, which has been studied in bipolar depression, and it didn't look very good either. So modafinil has been, like many things, it's been promising, but it hasn't delivered on what we expected. Okay? So it's a bit like Spain in the World Cup. We thought they were going to do good, but they didn't deliver what was expected. Right? And, you know, anyways, so it's a bit like Spain in the World Cup. It's got all the right names, it has the right profile, but it's not actually performing. Now, again, my personal opinion is that that is because we keep doing it the wrong way. I would like to see a study with modafinil for the treatment of cognitive impairment in major depressive disorder. And no one's done the adequate study yet. And I suspect it's going to be very helpful. The company called Shire did a study with one of the amphetamines known as lisdexamfetamine, and they showed that lisdexamfetamine is not a very good antidepressant, but it's pretty good at improving executive function. Not surprised to hear that. So that's why I've been using it, but the evidence is still quite thin.
Thank you, doctor.
Gracias, doctor McIntyre. Excelente conferencia, nos ha llenado de verdad satisfecho. Bueno, vamos a continuar con lo de este programa. Les recuerdo que esta tarde el doctor McIntyre tendrá otra intervención y en la noche una cena. Así que gracias a todos ustedes. Thank you, doctor.
Su atención. Necesitamos que vayamos a un break de 5 minutos para poder dividir el salón. 5 minutos.